Ok. Bueno, muchas
Very
gracias
well.
entonces por la
I'd
invitación.
like to thank you for the invitation,
Bueno, la idea
and
entonces es dar un overview, una presentación
I would like
general
to
del
provide
trabajo
an
que venimos haciendo junto con el doctor San
overview of the
Martín, con
work we've
Ariel
been doing together with
Gutiérrez
Dr. San
y un
Martin,
grupo de
with Ariel Gutierrez,
expertos
and the
con
group
la
of
idea de
experts,
desarrollar una guía de
with the
práctica
idea
clínica
of developing
basada en
clinical
evidencia y
practice guidelines
utilizando
based on
herramientas de estado
evidence
del
and
arte, como decía el
using
doctor San
the
Martín,
state-of-the-art
siguiendo la
tools, as
metodología
Dr.
de
San
GRADE,
Martin mentioned, following the
que
great
ahora, digamos, un
methodology.
poco la idea de la presentación
We
es mostrarles a aquellos que
we
no
would
están
like
tan
to
familiarizados
show you, for those
qué
who are not so
involucra
familiar with it,
hacer
and
una
show
guía de
what
práctica
it
clínica con
goes
esta
to
metodología.
create
Entonces,
clinical
en esta
practice
primera
guidelines with this
diapositiva,
methodology.
antes
This
que nada
first
quiero decir que
slide,
no tengo conflictos de interés, más allá
first
de
I'd
ser,
like to
obviamente, de
reveal
haber
I
participado
have
en
no
esta guía, como
disclosures besides having participated in
pero no
putting
tengo
together this
conflictos de
guideline, but I have no
esa primera
other
diapositiva es
disclosures to make.
resumen
What we see in
del
this slide is
proceso
a
de elaboración
summary
de una
of
guía
the
de práctica
process that
clínica basada en
takes to
evidencia,
develop
siguiendo
a
la
clinical
metodología
practice
GRADE,
guideline based on
entender el proceso
the
que debe
evidence and following the
seguir
great methodology, which I believe is the process that any clinical practice guideline based on evidence should follow. I will summarize this quickly. The first part is shown in the upper panel in green, and there is another one, which is the development of.
Ese proceso se llevó a cabo en una reunión presencial que hicimos en Panamá, donde participaron el grupo de expertos, eran algo así como 15 expertos, el grupo organizador y el grupo de metodólogos del que yo formaba parte. Durante un día o 2 días enteros discutimos cuáles eran las preguntas que tenían que abarcar esta guía. De una lista larga de preguntas se seleccionaron 12 o 13 preguntas que fueron las que terminaron siendo incluidas en la guía, y se seleccionaron esas preguntas porque se asumió que eran las preguntas más relevantes para ser contestadas, entendiendo que digamos, hay un cambio cuando uno usa este tipo de metodología y quiere sustentar las recomendaciones en evidencia. Es muy difícil abarcar absolutamente todo lo relacionado a una patología. Esto es algo que a veces es medio difícil porque es un cambio de paradigma. Entonces hay que seleccionar cuáles son las cuestiones más relevantes sobre las que uno quiere, digamos, emitir recomendaciones, y eso fue lo que hicimos. Después, en la parte verde hay todo un proceso de búsqueda y resumen de la evidencia, que en general está a cargo casi exclusivamente del grupo de expertos, aunque es fundamental tener feedback de los expertos en metodología, es fundamental tener feedback también de los expertos temáticos, porque suele haber cuestiones relacionadas a la selección de estudios, incluso al análisis de la evidencia que requiere de la participación de los expertos, y eso fue lo que hicimos. El resumen de la evidencia se culmina con el desarrollo de tablas, que ahí se ve muy chiquita, pero ahora les voy a mostrar más adelante cómo son. Esas tablas incluyen información sobre los efectos de las...
Those include information on the effects of interventions and the certainty about those effects. This is an important part that we have from the GRADE methodology. To be able to analyze certainty, we need to be able to analyze the quality of the primary studies to see if there's any bias, and other issues that are summarized on the slides. I will not dwell on this too much because of time constraints. Once this first stage finishes, the green part and all the evidence that is important to reach recommendations is finished, then that once that is summarized, we proceed with the second stage, shown in purple, where the evidence is presented and analyzed by a group of experts. In this case, that expert panel that had been formed, it is discussed in depth, and we create the recommendations, as I will show later. This is the list of questions. I'm not going to read them in detail, because my idea is to just provide an overview of the guidelines. In the short term, the document will be available, and you will have this information available. This slide shows a summary of how we search for the evidence. As you saw, there were 12 or 13 questions, and each of the questions required a systematic review of the literature. Those of you who are more familiar with systematic reviews, you know it takes a long time and a lot of work. So the idea was to try to use tools to shorten the time frames because we didn't have that much time to develop 12 systematic reviews. So the idea was to first look for systematic reviews that were already published, and from there on to identify the randomized studies and complement the searches of primary studies directly in the databases that are shown here. That's what we did. Next slide, please. And this is the summary with the overview of the work that was carried out for the guideline. Each row is one item, one subject developed in the guideline. For instance, the first row is related to warning signs and hospitalization criteria. So for that, what we did was a systematic review on prognostic factors for severe arboviral diseases. And the work led us to analyze almost 7,000 papers, of which we selected 226 that were summarized in 35 prognostic factors and 3 summary tables, which is what we presented to put together the recommendations. The second case was on clinical findings that allow us to differentiate between various arboviral diseases and from other diseases as well. And that led us to look at more than 8,000 papers. We ended up including 79 studies and built a table. And these were the 2 questions that applied a more workload. There's more information on prognostic factors than from interventions. And the other questions focused on interventions, for instance, on the management of IV fluids or oral fluids. And as you can see, the number of studies that we included was a lot less. The guideline included as well a couple of questions on non-vectorial transmission of the Zika disease, and we ended up including 5 studies also summarized in a table of results that we presented to the experts. I will now mention the work we did trying to summarize. This is a question related to prognostic factors. One of the most important questions that was considered by the expert group was what were the variables that should be used to determine that a patient has signs of alarm. So what we had to do was to review all the literature about the ability of these variables to predict that a patient with dengue, Zika or chikungunya was going to do poorly in clinical course. So what you see here is part of the table. The complete table is shown below. It's very large. And the information that we used for this question, we ended up including 229 studies because there were many studies reporting on potential prognostic factors. And each of the lines you see in color is one prognostic factor, potential factor that we explored. The information that we extracted was summarized here. This is information on one prognostic factor, in this case, the presence of mucosal bleeding. And all these were the studies that reported on mucosal bleeding as a potential prognostic factor with their estimations of effect. This information was summarized in a meta-analysis. So the results of all these studies were combined with one effect estimation, which is seen here. The numbers are small, but just to show you the process of extracting the information and summarizing it in a single estimation. And once we have the estimation for each of the potential prognostic factors, we need to analyze whether the estimation is reliable or not. And we have to use part of the GRADE methodology, which allows us to explore certainty of the estimated effect. And so here we see 3 prognostic factors of the 39 that we found with their respective effect estimations. There are some relative effects and others are absolute effects. That is, a relative effect that you see here with an odds ratio of 3. It translates into an increase in risk of 9.6% using a low baseline risk, or 20% with a high baseline risk. I'm not going to dwell in long technical explanations, but you can email me if you're interested in having further information. So could we go back, please, for a moment? Like I said, for each prognostic factor, there's an estimation. In this case, if you look for thrombocytopenia, there was high certainty. For abdominal pain, it was also high, and for hypoxemia, it was low certainty of the evidence. So we summarize this large table with 39 lines. We summarize this further into a table that could be more easily used. And we found the prognostic factors for which there was a high certainty of actually being reliable, like we see in green. Then there was another group where the certainty was moderate. And then there was another group of prognostic factors where the certainty was low. And those are shown in the lower row. For Zika and chikungunya, there was much less information. Could we go back, please? Therefore, we really did not find prognostic factors with adequate certainty for patients with Zika or chikungunya. Another example of questions that also was very difficult, implied a lot of work, and we see the clinical manifestations of patients with arbovirus diseases, and how can we differentiate between the three, and also how can we make the difference with other febrile diseases in the region. So we summarize the evidence again. The number of studies here was less, but also quite numerous. As you can see, a lot of information, and we summarize the results in this table, which is quite novel. In fact, I never saw a table like this. We had to design it especially for this question. As you can see, each row is a potential clinical manifestation that could make the difference between several diseases. And what we did was, for each column, we summarized the information we found to make the difference. For instance, between dengue and other diseases, or Zika and other diseases, dengue from chikungunya, Zika from chikungunya, and vice versa. Each of these estimations has a certainty of the evidence, and at the end, there is a summary of all those 6 estimations we found. Once again, this implied a large amount of information, which we summarized in a smaller table, more useful as well. And this is what we found. Above, you can see in green the clinical manifestations for which we have a high level of certainty and are useful to differentiate arboviral diseases from other diseases. In this case, for instance, articular pain or the presence of ecchymosis or petechiae. Then there are other manifestations with moderate certainty and others with low certainty. And what we see below in the table are the clinical manifestations that allow to differentiate dengue from Zika and chikungunya, Zika from chikungunya, and vice versa. For instance, the only clinical manifestations that we found with a high certainty that allows to differentiate Zika from the other 2 diseases was the presence of pruritus, and chikungunya articular pain, and dengue anorexia, hyporexia, or low platelet count, high hematocrit, and low level of white blood cells. Now we go to more classic questions that have to do with interventions. This one, I think, was one of the most important, was about the symptomatic management of patients with arboviral diseases, particularly on safety, because, of course, there was an important concern on the use of NSAIDs and bleeding. Unfortunately, what we found was not too much, and the certainty of evidence ended up being low or quite low. What we basically saw was that for the use of paracetamol, as well as the use of NSAIDs and dipyron, there is really no clear evidence about the adverse events, including bleedings, which could justify abstaining from the use of these drugs. However, as I'm going to use later, the expert panel discussed this evidence and the low certainty of the evidence and prioritized then the pathophysiological aspects and others that are already known, and that is why NSAIDs usually are not used. And that led to a recommendation in favor of the use of paracetamol of dipyron instead or above NSAID use. these are more classic tables. Here the question was of whether a transfusion of platelets should be indicated or blood components in patients with dengue and low platelet counts. And here we find a couple of randomized studies summarized into this table. The idea here was not to go in depth into the numbers. This will be available in the document to be published. But what we saw was that there was no reliable evidence that could support the use of platelet transfusions, since there was no reduction in the risk of bleeding or mortality in these patients. This is another question related to the use of oral hydration in patients with arboviral diseases. We summarized the evidence we found, in this case, based on a randomized study and an observational study, where we saw that aggressive oral hydration could have an important effect, especially in the risk of hospitalization. This led to a recommendation we'll see later. Another question was about the use of IV fluids. In this case, the evidence was summarized comparing crystalloids versus colloids. For this question, we found 4 randomized studies, and we obtained indirect information from other diseases. As you can see there, 69 randomized studies. All this was summarized, and basically the results of this body of evidence showed that there is no evidence showing that the use of colloids is better than crystalloids. In fact, they seem to be similar, with the added information that maybe crystalloids could have an adverse events, especially the risk of renal failure. Like I said, our idea is to provide an overview of our work. This was the general process, and I explained how we looked for the evidence and how we summarized them in tables. For some of the questions, not all of them, 50% of the questions were summarized, and I will now show you the process. Once we have the summarized evidence, we need to go from evidence to recommendations. For that, we also follow the GREAT methodology that proposes a framework for this and a series of aspects that need to be considered, not limited to evidence or certainty of evidence. There are other issues, as you can see here, which are quite relevant to be able to reach a recommendation. And this, what you see here is the summary of the framework of evidence of recommendations for the question of crystalloids versus colloids. This was discussed, and here is the summary of the panel discussion, which occurred 1 year after submitting the questions. There were 2 or 3 days of intensive work where we put together the recommendations. And this is a summary of one recommendation, crystalloids versus colloids. Like as you see, the problem was considered by the group as a priority. The group considered that the desirable effects were moderate, undesirable effects were trivial, of indicating crystalloids versus colloids. The certainty of evidence was summarized as low, and values and preferences of patients were considered. This is important. We search the evidence in this regard. Generally, there's not too much evidence on this, especially in these diseases. So the values and preferences of patients were considered, particularly in light of the experience of the group of experts. So possibly there is no important variability with regards to values and preferences of patients. So they judged the evidence, the balance favored interventions. In this case, it's crystalloids. Then they considered other relevant aspects that are related to resources, the financial aspects and use of resources. And the group of experts considered that for this question, the use of crystalloids was going to lead to savings in resources, possibly because they're less expensive. The issues related to the issues of quality, they seem to be, crystalloids are more available in the region than colloids. So if we recommend crystalloids, it will have a positive impact on the inequity issues. And also they consider that the use of crystalloid instead of colloids is an intervention that may be acceptable in most of the areas, and it can also, and it is easy to implement because in general it's available. So this led to one recommendation that I will show later. Another example of a recommendation, another example here. In this case, the question is whether we should indicate blood component transfusion for patients with dengue and thrombocytopenia. And as you can see, the colors vary, and the line of thought, the problem was a priority. Desirable effects were considered trivial here because, as I showed in the table, there was no evidence of benefit. Undesirable effects were small. In this case, the certainty of evidence was very low. But in this case, the balance was just as against indicating transfusion. They also considered the resources, and the idea of indicating blood components transfusion was going to imply high costs and possibly a decrease in the or increase in inequity because it's a resource that's not widely available in the region. As to acceptability, was probably acceptable, and feasibility was variable because there may be areas or institutions where this is feasible to implement, but in others maybe not. So all this led to a recommendation that I will show now. And finally, this is a summary of the recommendations. I will read them quickly, but all this, like I said, is going to be presented in the document that will be published soon. So for the first recommendation that related to clinical manifestations that allowed to differentiate arboviral diseases amongst themselves and from other diseases, what we did, we created a table that showed in colors that will be that can be used by the clinicians on site, and then using the information and prognostic factors that I used, a group of experts decided that the warning signs should be abdominal pain, lethargy, or irritability, mucosal bleeding, fluid accumulation, hepatomegaly, progressive increase in hematocrit, and vomiting. All those were signs of alarm. Then they proposed hospitalization criteria based on the same information, and all these include the warning signs plus the addition of the definition of severe dengue according to WHO 2009. Difficulty in breathing, shortening in pulse pressure, hypotension, acute renal failure, capillary refill abnormalities, pregnancy, coagulopathy, and finally, inappropriate or intolerant or fluid tolerance or intolerance. You recommended intensive oral hydration. That was a strong recommendation in favor. And then they suggested dipyron or acetaminophen over NSAIDs, steroids, or antihistamines for the initial management. That was a conditional recommendation. They also recommended early IV hydration for patients with dengue and warning signs. That was a strong recommendation. They recommended the use of crystalloids above colloids for the initial IV resuscitation for these patients. That was a strong recommendation. They recommended not to transfuse blood components, for instance, platelet concentrates in patients with dengue and low platelet counts, and that was a strong recommendation. The suggestion was not to use steroids or immunoglobulins in patients with severe dengue or shock-related dengue, and the other recommendations are related to sexual transmission of Zika. They recommended the use of condom to prevent that, and they continue breastfeeding mothers that could be possibly or infected with Zika or confirmed Zika infection. So these were the recommendations. My idea was to provide a general overview of the guidelines that really involved a lot of work and that we're now finishing and will be available shortly. Thank you very much for your attention.